So, good morning, good afternoon, good evening to everyone participating in this ISSM webinar on why do people experience sexual distress. It's a pleasure to welcome you all. I can see people are checking in. So please have the next slide. So just as a brief introduction for those of you who might not know ISSM, the International Society for Sexual Medicine, my name is Annamaria Giraldi. I'm located in Denmark and I'm the president of the society. And our society have both a vision and a mission. Our vision is that every human being has a right to a healthy and satisfying sexual life. And our mission is to be the most respected and trusted source of information, education, and professional development on human sexual health through the delivery of world-class publications, research findings, online and in-person opportunities for knowledge exchange worldwide. And I think that the topic of our webinar today is really related to a satisfying and healthful sexual life, because sexual distress is something that can be very painful for people who have a not satisfying sexual life. Can I have the next slide? Just to inform you how we are organized in the ISSM, we have regional affiliated societies in North America, in South America, in Europe, in the Middle East region, in South Asia, in the Asia Pacific region, and we also have affiliation with the International Society for the Study of Women's Sexual Health, and also we have the African Society for Sexual Medicine. So we have a reach out all over the world, and I think you can also see on the panel today that we have representations from different parts of the world. Can I have the next slide? If you are not a member, you could consider to become a member of the ISSM. One of the benefits of being a member is that you get access to our journals. We have 3 paper journals: the Journal of Sexual Medicine, the Sexual Medicine Open Access, and Sexual Medicine Reviews. And we also have our video journals on prosthetic urology. So consider to go to our website and see all the benefits of being a member of ISSM, or also make sure that you use the benefits if you're already a member. Can I have the next slide? So it's really a great pleasure to introduce the moderator for this webinar. Dr. Patricia Pascoal is a psychotherapist and a psychotherapy supervisor. She's an associate professor at the Lusofana University in Lisbon. She is the president of the Portuguese Society for Clinical Sexology, and she's also the coordinator of the Master of Clinical and Health Psychology in Lisbon at the university. And also she's very, very involved in the ISSM. She is the deputy editor of our Sexual Medicine Open Access, and she is the co-chair of our education committee and responsible for these series of webinars, which you have done such a fantastic job, Patricia. So it's so wonderful to have you today actually participating as a moderator. So I'll give it over to you. And I also want to thank our 2 speakers for participating in this webinar. And I can see we're already more than 100 people now that are going to listen to all your presentations. So welcome to everyone.
Hello, everybody. Hello, Annamaria. It's very good to be part of this project and to work with you, specifically with all the team. And I'm especially pleased to be involved in this webinar because sexual distress is a theme that is very important for me. I think most clinicians will recognize that distress gives meaning to the experience of signs and symptoms. And the discussion about distress in the field of clinical sexology is quite recent. We have been focusing a lot on sexual dysfunction and on function and sexual response, but the suffering that comes with it, we really need to address it and, discover their causes, the causes of this suffering, etc. So it's an immense pleasure to be here today, dedicated to this important theme. I would just explain a bit about the setup of the program, and so that people can understand how to interact and stay with us actively. So we will have the presentations. I will present the first speaker. I will end up make the transition between the first speaker and the second speaker. I will introduce the second speaker, and then in the end, after the second speaker finishes, we will be open for answering questions and answers. So what you should do if you have interest in some doubt you have, if you want to share something, the right way to do it is actually write it down in the Q&A part of the software, the platform, so that we can manage it. And I will make sure that I will look for redundant content or more relevant, because we also want the speakers to have the proper questions related to the experience. So in the end, we will look at questions and answers, and we'll create a lively, interactive conversation in between us and the people who are attending. And I hope I was clear with this. It's always difficult for a non-native speaker to speak in English and be sure if one's being clear. But I'll just introduce Shulamit Sperber. I hope I say the name properly. We've rehearsed the first name and not the second one. So Shulamit Sperber. She's a
Sperber.
How is it?
Sperber.
Sperber. Okay, Shulamit Sperber. Thank you. She's a dance movement therapist. She's a certified sex therapy, and she works at the Roth Relationship Center and sex therapy clinic, and she's specialized in body-oriented therapy. It is a pleasure to have you here, Shulamit. Thank you so much. It's amazing to have a woman experiencing sharing your experience and talking us from also your experience as a body therapist. So it's very good to have all this input. Thank you.
Thank you so much, Patricia. And I feel so honored to take part in this webinar. Very, very exciting. So today's talk will be about why do people experience sexual distress? Can we please go to the next slide? Okay, so I'd like us to start with a little database research in this article written by Kyle Stephenson and Cindy Meston. And they wanted to research the topic of sexual function and sexual distress, because recent studies have shown the sexual functioning and sexual related personal distress are weakly related in women, with only a minority of sexual difficulties resulting in significant levels of distress. So we understand that there is not a direct connection between sexual function and sexual distress. And they wanted to assess the degree to which relational intimacy and attachment anxiety moderate the association between sexual functioning and sexual distress in college-age women. And they gave out 200 questionnaires to women in the average age of 20, assessing sexual functioning, relational intimacy, attachment anxiety, and sexual distress. And the result of the study was that relational intimacy and attachment anxiety moderated the association between multiple aspects of sexual functioning and sexual distress. Next slide, please. So I present to you here a painting of Marc Chagall, because I love his paintings, and I think he makes beautiful images of intimacy. And what this study actually teaches us is that the sexual function is less significant than the degrees of intimacy, emotional intimacy, and levels of security and attachment for women. And an interesting finding of this study was that there could be cases of women who had no sexual dysfunction, but they were experiencing sexual distress because there were low degrees of emotional intimacy and high degrees of attachment anxiety in the relationship. And in other cases, there were women who were dealing with the sexual dysfunction, but not experiencing high levels of sexual distress because their relationships were strong and full of confidence and security. Next slide, please. So when we come to talk about sexual function and sexual distress, we need to remember the biopsychosocial model. So we know sexual dysfunction has a biological aspect. For example, a man can be suffering of ED because of diabetics, lack of testosterone, or some kind of disability. But there also is a psychological element, such as performance anxiety. And of course, there's a social cultural element of what is masculinity in our culture and what does it mean to be a man that is dealing with erectile dysfunction. And another example I'd like to give of social and cultural aspects of sex function, because I think it's very important, especially where I come from. I'm from Israel, and we have here a lot of faith-based communities. For example, a newlywed couple where the woman is suffering of vaginal pain, and probably the newlyweds would have preferred not to engage in intercourse and to get to know each other slowly, and practice non-invasive sex. But the spiritual leaders of their community are telling them that their marriage is not it's not consummated until they have intercourse. So they might be experiencing sexual distress and stress because of social and cultural norms. So we have to remember the biological aspect, the psychological aspect, and the cultural aspect. Next slide, please. And I want to give you some examples that we see in Reut Rehabilitation Center. So for example, if a couple in their 60s come to therapy and say that they have a problem, they have different degrees of desire, and one is interested in engaging in more sex than the other. There is no sexual dysfunction, but they are dealing with sexual distress because of the gap in the desire and the needs of each one of them. Or a different example of a young man who came into our clinic and said that he had an erectile dysfunction. But slowly, as I got to know him, I understood his distress was not caused at all because of that. He was a young man from a faith-based community, in this case, Muslim, and he had grown up in a community where homosexuality was considered prohibited and mental illness. So what was causing him distress was the conflict between his culture, his religious beliefs, and his sexual orientation. And I want to give you another example that I find very interesting about similar physical conditions that can cause and stem to totally different sexual distress. So we had two couples that came into the sex therapy clinic in Reut Rehabilitation Center. One couple in their 40s, they were a heterosexual couple, and at some point the woman had gone through a traumatic accident, and she had suffered a spinal injury, which made all the lower part of her body not have any feeling and sense. And they came to the clinic because they wanted to understand how they could have an intimate sexual relationship with their new condition. And she was experiencing very much distress because she couldn't feel anymore her genitals, and she was going through a process of grief and mourn over her loss. This is one couple. The second couple were a heterosexual couple, a man and a woman, who were both born with spina bifida, a deformation in their spinal cord. They had never had any, from the minute they were born, they never had feeling in the lower part of their body. And there was no distress caused to them by the fact they couldn't feel in their genitals. They knew how to be sexually aroused and experience very nice sexual relations by touching the upper parts of their body. What was causing them distress was that the woman didn't know how to catheterize herself, and every time she was sexually aroused, she would suffer of incontinence. So we see similar physical problems and completely different aspects when it comes to the distress. Next slide, please. Next. Okay. So how can we reduce sexual distress with our patients? How can we address the distress that they're dealing with? So we have the Plicit model, and it always starts with the permission. And each and every one of you here is a qualified mental health or a medical doctor who has a specialty in sexuality. So permission is allowing people to talk in a safe space about sexuality. And each and every one of you here are an address for people to come and talk about what they're dealing with. Limited information is the sex education part of our work. So for example, with the young gay man who came into our clinic, one of the most important things in the process that we went through with him was to teach him that homosexuality was not mental illness, was not part of the DSM, and rather it was a beautiful part of sexual human diversity. So that's the part of the sex education. And then we have the specific suggestions, which is the counseling part. For example, the woman with spina bifida, we sent her to a rehabilitation nurse who could teach her how to catheterize herself so she could be able to engage in sexual, intimate relations with her husband without being worried that she would suffer of incontinence. And then intense therapy, the part of the psychotherapy, sexual psychotherapy with the woman who had gone through the accident and had lost the feeling in the lower part of her body. Lots of the therapeutic process was about grief and giving space, safe space to experience the pain and the loss and the sorrow about the fact she would never be able to experience a genital orgasm anymore. Next, please. Next. Okay. So I want to give you another example of how we work with sexual distress in Reut Rehabilitation Center. We all know that treating symptoms of vaginal pain, vulvar pain, it can take time, women with dyspareunia. And we know it's a long process. There's aspects of physical therapy and there's gynecologists that are involved, but it can take time until the pain is reduced. So we understood that it's not like we can always make the pain go away, but we want to reduce the distress our patients are dealing with. So we opened up a support group for women who are dealing with vulvodynia, vestibulodynia, vaginismus. Most of them were women who had been in treatment for quite a long time, had been through physical therapy, and things haven't changed yet. And this support group was a very special thing because it was the first time these women could talk amongst peers about what they were dealing with. And it was a place to find identification and to talk about the shame, the guilt, the loneliness they were feeling. Some of them told us that when their girlfriends would go out for a beer and talk about their sexual experiences, they would always be quiet because they felt they had no legitimacy to talk about sexuality if they weren't engaging in intercourse. Another thing we tried to work on very much in this support group was empowering them as women, working on their body image. So we were working with them with yoga, with dance. We sculptured our vaginas, and we really tried to empower them and to remind them they're sexual women, whether they're engaging in intercourse or not. At the same time, we opened up a group for partners of women who were dealing with vulvar pain and vaginal pain. This was also very special because Israeli masculinity is very macho, and for these men to come and talk about how it was for them to be in a relationship where there was no intercourse was a new thing. And also many of them felt very much shame and guilt, and they had questions about what kind of a man am I if I'm not having intercourse. And some of them were experiencing feelings of guilt about them wanting to have intercourse and knowing that they can't have intercourse as long as their women were still suffering from pain. And on the other hand, there were feelings there of anger that why can't I have what culturally is considered, of course, not to sex therapists, but a normal sexual or proper sexual relationship. So this was a space for them, a safe space to talk about their feelings in being in a relationship where there's a pain issue. And I think this is an example of how we treat sexual distress and not only sexual dysfunction. Next slide, please. So the take-home message I'd like to give you professionals is our job as therapists is to understand what the distress our patients are dealing with stems from. And to address the distress, we shouldn't make assumptions. If we have a patient that comes in with a complaint, we need to understand more than the medical assessment, we have to understand what is actually causing them distress, and we need to address that issue. And we must be aware of the physical element, of course, but when we're dealing with sexual distress, the emotional element is the most important, and of course, not to neglect the cultural element and environment in which we are working. Next slide. So before we finish, a few weeks ago, I contacted Dr. Ruth Werstheimer in New York, and I asked her to send a message to training sex therapists in the Ut Rehabilitation Center where I work, and to send a message what she thinks was the most important thing for training sex therapists to know. And I thought, because this is the ISSM webinar and many people here are medical doctors, this message could be very good for you. So I present to you Dr. Ruth Wertheimer, that we all love.
Shalom, Reut. I'm Dr. Ruth Wertheimer. I don't have one best suggestion. I have 120 best suggestions. But let me try one. When you see a client, first make sure that there is no physical ailment. If there is a physical aspect to their complaints, send to a urologist for men and send to a gynecologist for women first. All the best to you sex therapists who work for Reut. I'm Dr. Ruth K. Wertheimer from New York City. Shalom.
So thank you very much, everyone. And that's the end of my talk. Thanks a lot.
Thank you, Shulamit. That was very nice and very good to hear you. And I especially liked that you called attention for the cultural norms and the historical context and how they shape the experience of distress. And you refer to a lot of important things we meet in our clinical experience, like guilt, shame, expectations. So very good thoughts. I would also like to remember the attendees that they can put their questions in the questions and answers chat, so that we can then interact in the end. And yeah, now it's my turn to present Sam. I'm fighting with the accent, as I told you. That's international events, we need to pay attention. So Sam, you can correct me in the end, but I'm going to try to do my best. Sam Geuens, who is a clinical sexologist and a psychotherapist connected to the PXL University College of Applied Arts and Sciences Healthcare Department, where he lectures on sexual health, counseling skills, and ethics. So important to bring this here to ethics, Sam. That's really good. As a clinician, he's connected to the Outpatient Center for Sexual Health at the St. Franciscus Hospital in Geuens, Belgium, where he counsels patients, couples with diverse sexual problems. Thanks for being here, Sam Geuens. I hope this is the right accent. It's not, but I tried.
Really good effort, Patricia, so that's fine. Okay, thanks for the nice introduction. And thanks, Shulamit, for giving a wonderful presentation. I'll try to connect to the story that you've been telling, going a bit more into the individual differences within couples and trying to identify why they might cause sexual distress, but also how we could, in therapy, try to bend them towards being a solution for sexual distress. Okay, next one. So let's start by thinking about sexual distress. If you look into the literature, the definition you'll often find is that sexual distress is a feeling of frustration, anxiety, or worrying with regards to one's sexual activity or sexual inactivity. One of the most important points to start with is that there's a difference between sexual distress and sexual satisfaction or sexual dissatisfaction. Satisfaction or dissatisfaction is not this frustration or anxiety feeling, it's more one's affective response to the experiences that they're having, both the positive ones and the negative ones, about their own sexual activities, about their own sex life. So there's a very important distinction here that needs to be made. Next one. Looking a bit further, it very quickly becomes clear that there's not really a one-to-one relationship between problems with sexual functioning and sexual distress, in the sense that physical aspects of, for instance, female sexual functioning, like experiencing pain during intercourse or pain with penetration, are generally speaking a poor predictor of female sexual distress. There will be a group of patients out there who are suffering from these kind of functional problems with their sexual functioning, both on an anatomical or a physical level, but aren't really experiencing sexual distress. Think about the women who are unable to experience vaginal penetration due to pelvic floor problems, vaginismus and stuff like that. But who aren't really sexually active, don't have a partner relationship, so probably they don't have anyone expecting them to be very sexually active. So their level of sexual distress about this problem with their sexual functioning will be much less great, much lower than of those women in the same situation who also have a partner who hopes that there will be sexual activity within the relationship. So that leads to the reflection question, when does something really become a problem? Is something a problem just because something isn't functioning anymore, because the body isn't doing what it generally, usually does with most people? Or is something else also needed to speak about a problem, call something a sexual dysfunction? And that brings us to the importance of sexual distress, of course, the distress criterion to make a difference between something that's just not functioning as it usually functions, or something that really can be seen as a sexual dysfunction, something that's really causing distress to the patients too. And I think one of the most important things I hope I can bring across with my small talk is that it's very important to direct our attention as clinicians towards stuff that really needs fixing, and stuff only needs fixing when people feel that it needs fixing. So when there's just something that isn't functioning, but people aren't experiencing distress about that, we really need to ask ourselves the question if we need to convince them to do something about it. Or is it okay to just leave stuff alone when people aren't really distressed by how their body is functioning the same or different than that of most people? Next slide, please. So what does research tell us about sexual distress? We have some proven predictors, stuff that makes the chances of experiencing sexual distress greater. Among those are multiple sexual problems occurring at the same time, or other mental health problems such as depression. Also, a partner's sexual difficulties. When your partner is experiencing sexual difficulties, this will also be a motor for sexual distress, even when you're not experiencing problems with your sexual function yourself. You might have sexual distress because of the problems your partner is experiencing with his or her sexual function. Low relationship satisfaction, and our individual attachment profiles. Those are all proven predictors to have greater chances of sexual distress. But a much more interesting link, in my opinion, from a clinical point of view, is the proven link between relational intimacy levels and sexual satisfaction and sexual passion. We see that for those couples where intimacy stays intact in whatever form it takes for this particular couple, then the chances of developing sexual distress, the chances of keeping yourself as a couple sexually satisfied, differ immensely. Those couples who can keep their intimacy intact, who still cuddle, who still have intimate conversations, who still spend a lot of time together, who hold hands, who kiss, will probably be experiencing less sexual distress from the same functioning problems. In other words, sexual distress, or experiencing distress or not, will be a part of the couple dynamic. Next slide, please. So if I have to be brief and blunt, what would be my core messages for clinical practice? That would be that if we look at couples, there's one thing that we can't rule out. What we will always have when we counsel couples is that we will find individual differences. No two people are the same, even if they're in love, even if they've lived together for tens and tens of years, there will always be individual differences within the couple. And often these are part of the causes for sexual distress. Think about some of the examples that Shulamit already gave. Couples will always differ in their levels of sexual desire. There will never be couples who have an exactly the same level of desire. There will always be one of the both who will be experiencing more frequent desire in this phase of their joint lives. So that will always be a difference. That's a given. You could say that that's normal. There will almost always be some differences in the nature of their sexual desire. What would they like to do when they're sexually active? How do they like to have sex with each other? What takes their fancy? What excites them? What would they like to try? There will always be some differences. And of course, moving away from sexuality, you will also have, for instance, personality differences that will affect how this couple functions on a sexual level. Easy example, think about a couple where one of the partners is someone who likes to be prepared for new experiences, who likes to have structure in his life, who likes to make sure that there is enough time to do what's important, whereas his partner might be someone who's very spontaneous, who's very in the moment, and who's very quick about new experiences. Well, also this will of course have an impact on how this couple arranges their sex life, and will make for a dynamic that they will have to search how they combine their individual personalities into a successful and happy sex life. Sexual distress and sexual satisfaction, we've seen that there's a difference between those two, that these are distinct entities. And the most important thing to take home for clinical practice is that these two are not communicating vessels. What I mean is, for instance, imagine yourself two thermometers, and you have one measuring the sexual distress level of your couple or your patient, and one leveling the sexual satisfaction level of. And what we tend to do too much in practice, sexologists, sexual health doctors, gynecologists, urologists, most of us sometimes make this mistake, is that we have patients and they present with a problem. They're experiencing erectile dysfunction, pain during intercourse, inability to orgasm, etc., etc. And they're experiencing distress about it. Too often we are still focused on the idea that we need to find out what is causing this distress, and that we need to try to alleviate the distress, bring the thermometer, the distress level to zero, taking away what's causing the distress. But one of the most important things to keep in the back of your mind is that even if you're extremely successful in doing this, getting their sexual distress levels down to zero, that still doesn't mean that your patient will be sexually satisfied. Even if you fix a man's erectile dysfunction, and I don't really mind if you fix it in a medicinal way, or if you fix it with psychotherapy, but let's say we fix it and his erection is functioning again, he's no longer experiencing distress about that. That doesn't 100% clear make sure the fact that he will also be sexually satisfied by now. Because if this problem has been happening for some time, it has affected the couple dynamic. And probably even now that he knows that his erection won't fail again, he still has to get over the threshold of engaging in sex again with his partner. And even the partner might have been experiencing distress and might have developed non-functional thoughts and thinking patterns like, does he even feel I'm sexy anymore? Does he still want to have sex with me? So this couple still has a way to go before they're sexually satisfied. Fixing the problem, taking away the cause for the sexual distress, will not automatically lead to the patient's goal. And the patient's goal often is a happy sex life. Not just fix my erection, take away my pain. The goal will often be a happy sex life. And that's much more than fix the functioning problem. So both these levels of sexual desire have to come, of sexual dissatisfaction, we have to come down, the levels of sexual distress that have to come down, but also those levels of sexual satisfaction that need to go up, deserve attention in a simultaneous way. Because in the end, we want our patients to be very sexually satisfied. Next slide, please. To go to a practice example, for me at the moment in the clinic, I'm counseling a lot of women or couples who are suffering from vulvodynia, pain problems with any kind of penetration. And in seeing more and more of these patients, I think it's very important to keep asking oneself, why would this problem, why would this vulvodynia problem be causing sexual distress? And if you start to think about it, you very quickly come to the realization that there's distress being caused both on an individual level, but also on a couple level. These patients tell tales about how they worry that this might be affecting their partner's view of them as a woman, their partner's view of them as a suitable life partner, their partner's commitment to the relationship, etc., etc. But also on an individual level, often these patients are wondering, what does this mean about my womanhood? They're experiencing shame, they're experiencing guilt. So these causes for sexual distress are multifactorial and also occurring on different levels, both individual and in the couple. So if these causes are so diverse, the next realization is then probably what people would want to achieve by coming to us as healthcare professionals, what these patients are trying to achieve by going to their gynecologist, going to a sexologist, etc., could be as equally diverse as what's causing the distress. So we need to think about what suitable therapeutic goals would be for these patients, for instance, these vulvodynia patients. Next slide, please. The easiest way to go about this is by asking the experts. And who is the expert about what the therapy goal should be? That should never be the clinician. That should always be the patient. No one knows as good what she wants to achieve as the woman sitting in front of you. So ask her, for every patient again, what do you hope to get out of therapy? What do you hope to achieve by coming to me or to us as a team and presenting your problem with us? What would be the best thing that could happen from making the decision to come in and to talk about your sexual problem, to talk about your pain problem? And then quickly realize that these goals that patients have vary from case to case. And they're always more than what's obvious. For these vulvodynia patients, their goals are always more than just being pain-free. Of course, they also would like to have pain-free vaginal penetration with fingers or with a penis or whatever. But there are always other goals on top of that. Often not just individual ones, but also couple goals. They would like to experience sexual desire again because they've lost that somewhere along the way. They would like to rekindle their relational intimacy, spend more time together again, cuddle more, kiss more. They would like to develop more closeness in general again. Individually, they would like to experience less sexual shame. They would like to feel less like the brakes are on when they're with their partner, less afraid to engage in sexual activity, less afraid to show their sexual interest to their partner. And it's very important to do this exercise with those clients, because if we try to motivate them to just work on being pain-free by going to pelvic floor therapy, engaging in gynecological examinations, etc., it might just be that we're not working on those issues, those goals that are most important for them at this moment. Often I have women telling me that of course they want to be pain-free, but the most important thing at this point in their life is finding ease again in the idea that their partner won't leave them, that the partner still thinks that their relationship is worthwhile. Often they will say, I would first like to find some intimacy again. And of course, when the pain would be gone, I would like to rekindle my sex life also. And patients will always be most motivated and work the hardest when we're working towards their goals and working towards those goals they have that they feel are the most important at this point in their life. So we actively need to ask them and model our therapy process, our treatment towards what they want to achieve, and always realize that it's more than just trying to fix the functional problem that they're presenting with, because probably that's not the only thing causing sexual distress, if it's even causing distress. Next slide, please. So what do I hope that you take home from this? I hope that you take home that it's very important that when you're meeting new patients, that you always, and I would prefer really in that intake, in that first contact that you have with your patients, that you make time to find out what their goals are. Focus on their own goals. Don't think this is the 100th patient with erectile dysfunction, with vaginal pains, who is unable to experience desire again, but realize that they're all unique. And start with them, start with their stories, and ask what they would like to achieve. They might surprise you. It might be more than meets the clinician's first eye. Engage with them from a not knowing stance. Don't presume to know that you already realize and know what they need and what they want to achieve. No, ask them. They are the experts. And for couples, if there are individual differences acting as factors who are creating sexual distress, try to locate them and try to turn them around and make them sources of potential solutions. If one of the partners feels it's very difficult to talk, the two of them, about their sex life, but the other has less effort with this, turn it around. It's not a problem because one of them has difficulties talking about sexuality. No, they're lucky. One of them has no problems talking about sex. So he or she can actively help his or her partner to get over the thresholds that are standing in the way of a plain and simple conversation about their sex life. They can, in other words, teach their partners the skills that they're lacking. If one partner is more sexual experienced than the other, the less experienced partners sometimes experience feelings of insecurity. Turn the problem around. They have someone with them that is more experienced. That means they have someone they trust that they can learn from, and try to get couples who come into your consultation chamber thinking this is a problem, get them to leave your consultation with the idea this could actually be part of the solution. If one of them is ashamed about what's happening sexually or not happening sexually, and the other one isn't experiencing that shame, have the shameless one tell you as a clinician how he manages not to be ashamed in this situation. So his or her partner can hear this and might learn something from it that will benefit both of them. Next slide, please. For those of you who want to get into this a little bit deeper, I've included those references. So I hope this was something that you can really take home to your clinical practice, both as sexologists, but also as gynecologists and as urologists, because I know it's somewhat of a challenge for all of us, no matter what our background is, to not always presume that we know what our patient wants and we know what our patient needs. They often surprise you if you just ask the question, what would you want to get out of coming to therapy? What do you like to achieve by getting treatment in this situation? And I guarantee you, you will come to patients whose sexual satisfaction levels will rise. Thank you.
Thank you, Sam. It was a pleasure to listen to you, and especially that you talk about stress as a result of process within a relationship, and that you also stress the importance of individual factors on the creating the experience, I would say, the experience of the stress. It was also very positive, and one of our attendees highlighted this. That you focus on the not knowing stance, on the collaborative nature of a clinician's work, and I would say meaning making, creating meaning together with our patients. It was good to see these issues being brought to us. I think we can, at the moment, I think it would be okay if Sam and Shulamit would open their videos, because yeah, I would just kind of raise the questions and direct it a bit freely to any of you. So we have some questions, and I'll try to create a narrative on the questions raised. Somebody says I have much echo. Okay, I will try to improve that after I say this one. Okay, so the first one is, how can we measure, how can we assess stress in a clinical setting?
Sorry, Shulamit, would you like to take this question, or?
How can we assess the stress in the clinical setting? So I think this is something that we'll learn from our patients. When people come to seek guidance and therapy, they come and they talk, and if we listen, we'll hear what they're dealing with and what they're suffering of. And I don't know if it's at least for me, I can say it's not possible to assess the degrees of the stress. But of course, I can tell you that if a patient comes, I'll give you an example. We can go back to the example of a homosexual man in a faith-based community that believes homosexuality is a sin or mental illness. Of course, he'll be experiencing very high levels of distress. Or if we have, we were talking about vulvodynia and vestibulodynia. So I think it has a lot to do with culture. When you're, for example, also in Israeli faith-based communities, there's a lot of pressure on newlyweds to have children. And when there's a couple that can't engage in intercourse and don't want to go immediately to getting treatments for fertility, it can cause very much distress. In some communities in Israel, marriage is not only a matter of a couple, but also families are involved. So of course, we'll see high levels of distress. I don't know exactly how you can assess, but I think we can feel our patients and see their pain.
If you want to make that really practical, what you could try doing, if you want to experiment with that in a clinical setting, is using scaling questions. A bit like we do for pain, but then with a bit of a twist around it. You could easily ask your patient, well, you tell me that you're really feeling distressed about what's happening. Let's, for instance, try to put your distress on a scale from 0 to 10, where 0 is absolutely no distress. And then you ask them about another distressing event in their life that they remember. You have them explain that event to you. And you say, well, if that event is a 10, level 10 distress, and 0 is no distress, how much distress are you experiencing because of the sexual issue? And that will give you somewhat of a, it's not objective, but somewhat more of a direction about how big this the sexual issue is for them.
I was just thinking, and this is the moderator asking, not an attendee. I was just thinking, because of your talks, I was inspired on my own thoughts. And I thought, okay, assessing is also assessing the sources, right? Are you distressed because of you, your expectations, or from what is expected from you, from your relationship, whatever the relationship is, or what culture, or what you perceive culture is putting on you? I'm not sure this, it's not really a question, it's just sharing that when we are evaluating, we should also try to differentiate where does the pain come from, where does the suffering come from? Because sometimes it's just, you know, people are not living to the standards they think the others have on them, or the culture imposes on them. Do you agree with this?
Absolutely. I totally relate with what you're saying.
Yeah, this leads me to a question from one of the attendees, that one person is asking how to handle distress for religious reasons.
I couldn't hear how what?
How to handle distress for religious reasons. Yeah, that's one of the attendees is asking specifically for, maybe I assume, some help on how to dealing with when this distress comes from the outside.
If I have to be open about clinical practice that I had with this kind of thing, is I'm the first one to admit that sometimes the clinician isn't the best professional to help people with distress about religious reasons. I remember counseling a patient mid-40s, also struggling with homosexual and gay interests. And I've had numerous sessions with him, and we were making some progress. And at a certain point, we went looking for someone within his religious community, which was a Roman Catholic community in the Netherlands, a Roman Catholic priest in the Netherlands, who would be open to talk about the place of homosexuality within the church. We found someone. He had one conversation with that priest, and that fixed much more than I did with my 5 previous sessions. So sometimes it's also good to think about, am I the best person to help with this part of the situation that my patient's in?
Wow, that's a beautiful story. And I want to say that something that we do in Israel, and especially and specifically in Re'ut Rehabilitation Center, is we do have connection, for example, with rabbis. And then if the patient, of course, allows us and is interested, we ask them for counseling and maybe to have a talk with the patients, and we do co-work together. So I'll give you a little example. When we're talking about vaginal pain and vulvar pain, so we presented a halachic question. Halacha is Jewish law, to a rabbi, and we asked him to rule that according to Jewish law, there is no problem ejaculating out of the vagina when there is sexual dyspareunia, because many couples would come over and say, we think it's prohibited to ejaculate and not in intercourse. So we had a rabbi give a ruling that there's no problem, and when there's sexual pain, there should be no intercourse. And that helps us. We can present this ruling to our religious patients and help them know they're free of guilt and shame.
We also have a a question about, I think this one, we can have a straightforward question. It's actually from one of my PhD students, Katerina Repos. She's studying sexual distress in her PhD. And she asked, how do you perceive the impact of sexual distress on people who are not in a committed relationship? Because, I mean, you both talked a lot about committed, ongoing, etc. I think this is a good question. Are there specific processes or maybe specific questions that are raised?
Well, I think one of the first things would be to thoroughly understand what this person's relational context is. But even if you're not in a committed relationship, you are people who are choosing not to be sexually active and who are fine with that or not fine with that, or you have people who are engaging in multiple flings or separate sexual contexts who are fine with that or experiencing distress by that. For me, a couple or an individual, I would still use the same kind of techniques. I would still, for instance, try to put their distress on a scale to get a bit more of a handle or a feeling about how big the impact of the distress is on their daily lives, how much it's causing them to keep focusing on the distress even when they're performing other activities, etc. How I go about assessing that wouldn't really be different in a clinical point of view for couples or individuals.
Okay. Shulamit, do you want to add something?
Yeah, and not about assessing, but I do want to say that we work a lot with individuals that are not in relationships. And of course, we can see there are a lot of sexual distress relating dating and getting to know people. For example, if I have a woman that's dealing with vulvodynia and she says, I'm avoiding dating because I'm worried of the second we're going to get into the bedroom and what am I going to do? So we need to talk to her about the option of telling people, even if she's having a one-night stand, I'd love to play, I'd love to have a nice time together, but I don't do intercourse. Or a young man who's dealing with ED and is very, very worried of going out on dates or trying to have one-night stands if that's what he wants, because he says, what am I going to do with her if I don't have an erection? So to help him with his confidence and make him understand that his masculinity is not assessed by his erection, and that he can be a very good lover even without an erection, and to try to ease the anxiety he's dealing with.
Okay. Okay, just to kind of close this part of the discussion, because we are talking about dynamics and relationships, I have one question here, as actually I was texting about it privately on my WhatsApp with some people. So it's partly mine, partly from some people, which is you were talking about the cuddling, the tenderness, and getting together and all how this is important. And we was thinking, can we talk about these positive couple processes as protective factors from future distress, or actually they are minimizing a distress that is already there? And so it's about being a cause, or being,
For me, the answer would be very straightforward. It's both of them.
Okay.
Think, for instance, about couples who get pregnant. It would be very interesting to counsel them to keep both sexuality and intimacy alive during pregnancy. And if they're choosing not to be sexually active again because it doesn't feel comfortable or whatever, or because there are really risks because of high-risk pregnancy or whatever, keep the intimacy alive. Because if the intimacy is still there afterwards, X number of weeks or months after birth, they will have a much easier time getting their sexuality started up again also. So I think it's both a protective factor for future distress, but also a minimizing factor for current distress sources.
Okay. Thank you, Sam. Do you want to add something, Shulamit?
I agree with every word that Sam said.
Okay, we have now a question. I will not jump into the next section yet, because now it came a question that says, what about sexual distress in asexual individuals? And I think this is very interesting, because we were talking all the time about balances and processes and dynamics. How can they learn to deal with it when in a romantic relationship? How would you work with a non-asexual partner? So I think we need some straightforward answers for that too.
If I can go back to something I said during my small talk, for instance, with this kind of patient, it will be very important to ask them, what do you hope to achieve by coming to me? What would make coming to me a success? And probably she will or he will give me answers that I couldn't have predicted beforehand. Because some of these asexual individuals, some of these asexual people still feel okay engaging with sexual activities with their partners, whilst others feel thoroughly uncomfortable while doing this. So only that difference will lead to very different therapeutical goals for these patients. So I think if you focus on what they want to achieve, then probably you will very quickly learn from that what you can do to help them achieve what they want to do.
Okay, Shulamit, do you want to add something?
I want to add, I agree very much with Sam, and I want to add that I think when we're working with asexual people, it's very important to use LGBTQ affirmative therapy, and first of all, really give them a feeling that it's no problem and it's fine, and of acceptance, and then really, like Sam says, to see what they would feel comfortable, because many asexual people are very romantic people, and to try to understand what kind of relationship they see themselves feeling comfortable in. Coming out of a perspective of acceptance, of them knowing they're fine the way they are, just seeing what would be good for them.
And if I read the question, it's also about how would you work with a non-asexual partner, so just a sexual partner. Same applies. What does he or she need to be happy in the relationship? It will differ from case to case. So you have to start by getting both partners their goals on the table, and then trying to find some middle ground or a way to combine this into what could lead to happy couplehood.
Yeah, I think we are just missing one magic word, which is expectations too, right? Which is and this leads me to the next set of questions. So it's kind of, I'm asking something that has come up from a lot of different people, which is the role that actually physicians and doctors and the medical discourse has had in shaping and creating experiences of distress by prescribing in a way what is normal sexuality, or what the sexual response should be, or how people should live their sexual life. But I think here the question is really, how do we deconstruct this together as a community of clinicians too? And I think we are not talking about normalizing everything to the point that we do not recognize distress, but really focusing in how we as clinicians sometimes maybe on purpose or not, it doesn't matter, but the question is, we also have a role here, we have a responsibility, right? Aren't we sometimes contributing to this kind of pandemic discourse about, oh, your sexuality is not okay, you should be functioning better? And how can we work with this? How can we work with this?
One of the things that comes to mind for me when you're asking the question, Patricia, is you start by asking what you hope to achieve in therapy in your first session, but every X number of sessions, you evaluate if the patient still feels that you're working on what they need and doing what they find is important. So that not somewhere along the way you've drifted back into the idea that you need what your patient needs, and that you're actually again steering the process. You need to actively keep evaluating that they're steering the process. And I think doing this within multidisciplinary teams, so that also people from different backgrounds, the gynecologist, the urologist that you work with as a sex therapist or as a sexologist, can experience that if you do this, that your joint patient will be experiencing less distress and will move along quicker. If I come to my vulvodynia example from earlier, one of the things that often happens now is they go to my colleague, which is a very good gynecologist. I'm very happy to work with her. She prescribes creams that have to be applied to desensitize the neural endings that are causing the pain, et cetera, And very often, if afterwards I see them and I ask them what would make it useful coming to me today, one of the first things that they say is, I would like to talk through with you exactly how I should go about applying this cream, because it hurts every time I have to apply it and I have to do it twice a day. So if I then spend time on that, 2 months later, when they come into my colleague's office again and she does a gynecological examination, we've learned that in the years that we've been working together, that patients are progressing more quickly, because now we've identified that many of these need have the goal of being counseled, and how do I go about my medical treatment. And now we make time for this, and they get to where we want them to get them more quickly, also on a physical level. And these experiences, I think, help our medical colleagues to realize that if we take some aspects out of the more psychotherapeutical playbook too, that this will benefit them too, because this will get patients who are actively going about their physical treatments better than they were before. So I think it's lived experience as multidisciplinary teams that will really get us where we need to be.
Shulamit, do you want to add something? I think Sam is stressing the importance of working as teams, and that we also look at our own meanings and the meanings we give to the experiences of our patients. I can imagine also the way we read literature and the way I think we need to also look at our context. And we know that sometimes our context is a context who promotes disease as a need for our jobs to keep going. And some experiences, I'm sorry to be so politically not correct, but I think the question is here sometimes, how can we normalize some experiences, or actually not normalize, but create the atmosphere that says to people, this is not about you, you are not wrong. This is about a lot of discourses that have been built up to regulate your bodies. Exactly. And I think, as far as I could understand, Sam, you were also saying that in a multidisciplinary team, we can create this discourse together, and we question ourselves and our practices, and how we are maybe sometimes being part of the problem by not creating the opportunity of blooming, and by prescribing ideas, or even, I don't know, whatever.
And we need to take pages out of each other's playbooks. I need to keep realizing, as your wonderful Dr. Ruth gave the message, that when I get a new patient who comes directly to me, and I hear physical problems with functioning around sexuality, that I really need to get them to go to the gynecologist or go to the urologist, so that I don't miss physical aspects of the problematic situation beforehand, because otherwise I can talk with them until the year is round and we'll get nowhere. And in the same way, I hope the medical colleagues will take a page out of the therapeutic playbook and ask patients what they want to achieve, and not presume that they know what patients want to perceive, not just being pain-free, but much more than just being pain-free, or much more than just a functioning erection. So I think it is lived experience as multidisciplinary teams that makes us realize that if we take advice from each other, that we get our patients much sooner to the point that they're sexually satisfied again.
I was also thinking that sometimes, as far as my experience is, I know, meaningful. I don't know if it is very meaningful for me. It is, but sometimes what I feel in my colleagues and the people I'm supervising is that the urge to be helpful, of giving a solution. And that's what Sam said, and you too, Shulamit. At first, we have to create meaning together, instead of just going into the narrative and not really understanding what it's behind this. Maybe it was a TV show. Maybe it was somebody said something that made these people feel awkward and uneasy with the relationship or whatever. I think we all have responsibility on this, and I think we have to finish. I'm so sad, but we have still a lot of questions, and I'm very sorry for the ones that people feel were not addressed. But that's time to go. And as a good Latin person, I'm already a bit late. We should be finishing, but it's good sometimes to stay longer. It's good sometimes to reinvent ourselves. And before closing, I would just like to try to make a bit of a sum up, or wrapping up what I think are the take-home messages. So, be aware, distress comes from It can come from personal experience, mental health, vulnerability, personality. It can also be derived of relationship dynamics, how your partner may feel you, how unbalanced in the relationship. It can affect any kind of identity. Asexual people who are in diverse type of relationships may experience distress. So it's not exclusive experience of people who are in a couple or something like that. It's something we need to be aware of, and we can never neglect our role as clinicians, as also someone who can be part of the problem with our discourses and sometimes our training that tells us that something is a problem, and and that we know we have a history being built in sexuality. That culture sometimes promotes some problems, and we know we have distress that comes from people who are being persecuted because of their relationship orientation, their sexual orientation. That is also a form of distress we didn't address today. And and the medical discourse sometimes doesn't help, and we must be aware and we must pay attention. Is this a good sum up, Sam and Shulamit? There was some tips for those who were asking in the questions and answers on Sam's presentation. Shulamit also addressed some tips to minimize distress and promote sexual satisfaction. I think you can ask for the presentations. And just a quick comment before I close up is, I find it very interesting, Sam, that you put satisfaction and distress as kind of complementary experiences, because I always put pleasure and distress. I was wondering, why is he focusing on satisfaction, not pleasure? So maybe we can talk about this in another session. Thank you all. It was I'm very thankful for the people who are, saying thank you and giving good feedback. It's so good to receive good feedback. We work very hard, and and it's good to feel that you are here with you. We want to thank all the participants, and I always thank the participants first, because you are the ones who create meaning to the experience. Also, of course, Sam, Lillian, Annamaria, all the people who are here, Shulamit, everybody. The slides, as I said, will be available on demand. And yes, we will now show the announcement for the next webinar. So I hope we can count on you. We hope we can count on you. And feel free to criticize, giving ideas, because our work only makes sense if we work for all of you. Thank you.